Hello everybody and welcome. Today I'll be presenting on ethical principles and recommendations for medical management of differences of sex development, DSD, intersex in children and adolescents. My name is Emma Louise Saddington, student number 170-72771, Bioethics in Healthcare, from the Masters of Public Health, Masters of Health Administration, Trobe University. Based on a true story. Herman 2002 discusses that in November 2000, a 4-day-old infant lay supine on the operating table at a children's hospital in the United States. The child was draped and prepped for surgery. The child's problem lay exposed to the view of the urology residents, who crowded the operating room. Rather than male or female genitalia, the child had a tiny phallus with a urethral opening in its base, 2 bifurcated scrota which appeared to form a labia minora, and a vagina which ended blindly, rather than leading to a uterus. The child's gonads were nowhere to be found. The surgical task was to find the gonads and take a sample of them to determine whether the other matters were comprised of testicular or of ovarian material. Upon analysis of the specimen, the laboratory found both types of tissue. The infant was neither a male or a female, but was called intersex. The facts. Intersex individuals are classically defined as having both male and female characteristics. Researchers estimate that intersex conditions may affect up to 1 out of every 2,000 children born. Intersex, by definition, is classified as a condition consisting of blending of the mix of internal and external physical features, usually classified as male or female. For example, an infant with ambiguous genitalia or a woman with an XY chromosomes. For over 40 years, doctors have been in the impossible situation of making monumentous decisions for intersex children. These decisions across the years have notoriously been made without well-founded scientific principles and with little more to guide them than a personal hunch that they were doing the right thing for the child. Furthermore, literature from Cretan 2001 states that despite rapid advances in understanding, sexual differentiation and increased accuracy of diagnosis, the clinical management of intersex has changed little. Recently, the medical profession has been confronted by the powerfully critical voices of intersex consumer groups, with a serious deficiency of any evidence base, emotive debates on ethics, and clinical concerns over the long-term consequences of interventions. It's time to stand back and rethink every aspect of this management. Literature overview. Principles and recommendations for DSD or intersex children were built upon high levels of respect for the individual and their self-determination. Weissman et al. 2009 noted that upholding different ethical principles such as patient autonomy, benefits and non-maleficence could help to lead to inconsistent conclusions that may involve immediate treatment decisions. With this information on board, decisions made by parents for their children must be carefully weighted and given the breadth and scope required to make the right choice for the child and their family. Literature from multiple authors focus on the high level of respect required for the individual child and family. No 2 cases are the same, and no 2 cases should be treated the same. Furthermore, Weissman et al. 2009 stated that from a biological perspective, these conditions have been multifaceted manifestations, including incomplete development of sex anatomy and or the involvement of disturbed production of sex hormones. When a child is born with ambiguous internal or external genitalia, the affected child and their families and loved ones must make decisions from a very early on post-birth of what the rest of the child's life will consist of in relation to gender identity. The critical analysis. Thien et al. 2005 posited that biologic factors contribute to gender identity gender role behaviour, and sexual orientation in humans. Furthermore, Thine et al. 2005 states that gender identity of an individual denotes the conscious and unconscious feelings of belonging to one sex or another. Thine et al. 2005 agrees with Weissman et al. 2009 that gender identity can develop in the sequence of extreme, complex interactions of both biologic and psychosocial factors. Both these authors put forward the importance of an atypical gender development and studies on psychosocial well-being. Moreover, both of these authors acknowledge that the professional debate continues on the issues of deciding the most appropriate way of determining sex assignment in children. In addition, Thine et al. 2005 shows evidence that given the knowledge surrounding the causes, treatment options, and long-term outcomes, which include patient preferences, are extremely insufficient. Both Thine et al. 2005 and Weissman et al. 2009 need to conduct further research in this area of bioethical principles to continue to be delivering current, evidence-based research that correlates into practice on such a high emotive and extremely important issues surrounding DSD and gender assignment. The discussion. The summary of DSD and intersex issues are outlined by Weissman 2009 and are as follows. Point 1. DSD is not a surgical emergency, however may be more psychosocial. If there is no immediate danger to the child's life, decisions need to be made carefully. Point 2. The child and parents must have the right from the start to be involved in the elements of their child's care. Point 3. Noting that the child's well-being is not automatically ensured just by determining an external, biologically ambiguous sex, further development on the child's self-confidence and self-esteem surrounding their gender will be required long into the future. Point 4. A robust therapeutic stance from the beginning of being open, accepting, must be encouraged by the child, their family, and the entire multidisciplinary team who are involved within their care. Point 5. Any interventions that are made must be completed on the basis of having the best possible outcome for the child and the overall family situation. 6. In some cases, reasoning and justification are required when interventions are being contemplated, which are not substantiated by conclusive scientific evidence. Point 7. The child at hand should continue to be given information and education about their condition that is age appropriate throughout the years. Point 8. The right of the future adult to obtain information about the treatment received during childhood must be withheld and through a unified documentation process. And finally, the principles and recommendations that are discussed above must be reviewed on a regular basis to ensure they remain evidence-based and appropriate for the situation. The recommendations. We require greater prenatal testing for DSD and intersex to prepare parents and families of those infants. There needs to be an increased education program postpartum of the process of what will happen in the coming weeks, months and years for their child. Further research must be conducted in DSD and intersex to allow for parents and families of these children to make educated choices and feel comfortable that they have made the most well-informed choice. And tighter regulations internationally to ban any surgery on the child can be proactive until the child can be proactive in the decision and be of consenting age. So, to conclude, there are 3 leading ethical principles that have been highlighted by Weissman 2010 and can be applied to DSD and intersex infants and children. These are to foster the well-being of the child and future adult, to uphold the rights of the children and adolescents to participate in and or self-determined decisions that affect them now and well into the future, and to respect the family and parent-child relationships along the way. the overall social contribution. DSD and intersex infants and children have for some time attracted a lot of attention by paediatricians, endocrinologists, psychologists, geneticists, feminists, ethicists, and self-help groups. Looking into the future, we need to collectively decide on the role that medicine should play when shaping sex and gender identity in children with DSD or intersex. Now, with a shift in paradigm, the groups, as stated before, have helped outlaw the so-called optimal gender policy. Current practice is that other than the case of a medical emergency, there is clear guidelines for a moratorium in any feminising or masculinising operations before full consent can be gained from the child. This is otherwise known as the full consent policy. Some questions to take home. What does consenting age mean? How old is this? How do you adequately deliver counselling for children with DSD or intersex? What needs to be included in this counselling? And who should have the overall power to make the decisions? Is it the parents, the child, or the medical professional? Thank you for your time and have a good day.